Chairman IMA MSN Dr. Jaspal Singh Telia sir, Coordinator Dr. Ravin Alva sir, and our esteemed speakers Dr. Vatsalya HG and our moderator Dr. Prakriti Aryakumar ma'am and other office bearers and the dear medical students. A very warm and pleasant welcome to you all to the today's webinar. I, Srinidhi S., co-convener of IMA MSN Karnataka State Branch, feel honored to welcome to this webinar on emotional processes and associated mental health conditions. Continued webinar, which was first part was taken on yesterday. So thank you all for joining us this evening. To begin this session, I now invite Miss Shreya S., PRO IMA MSN Karnataka to lead us with IMA prayer.
Thank you, Srinidhi. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure.
Thank you, Shreya. Now I'll be proceeding with flag salutation. We, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it and realizing our responsibilities as the accredited members of this national organization. We swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Jai Hind, long live IMA. We now move to the academic segment of today's program. To formally introduce our esteemed speaker, I now invite our moderator, Dr. Prakriti Aryakumar, Head of Community Care, Clinically Evolve. Ma'am, over to you.
Good evening, everyone. It is my honor to introduce our first speaker for today, Dr. Vatsalya S. Gowda. Dr. Gowda completed her MBBS from JSS Medical College under JSS University. She pursued her MD in psychiatry from JJM Medical College and further strengthened her academic credits by earning her DNB in psychiatry from National Board of Education. She is currently serving as an assistant professor in the Department of Psychiatry in Kempegowda Institute of Medical Sciences, Bengaluru. With special interest in child and adolescent psychiatry and psychosomatic medicine, and as a recipient of Must Enrich Research Grant for Psychiatry Teachers in 2021, Dr. Gowda brings both academic rigor and rich clinical experience to her work. Today, she'll be speaking to us on obsessive compulsive disorder, a condition that significantly impacts functioning and quality of life, yet is often misunderstood. Please join me in warmly welcoming Dr. Vatsalya S. Gowda. Over to you, ma'am.
Thank you so much for that introduction. Just checking, am I audible?
Yes, ma'am, you're audible.
Right. So we'll start.
Yes, ma'am.
So is my slide visible to everyone?
Yes, ma'am.
Okay.
Yes, ma'am, it is visible.
So yesterday an introduction has been given already regarding what are the emotional processes and how they operate in various mental health conditions. And I believe an overview of anxiety disorders has already been covered yesterday. And just moving forward, today we are going to discuss another important topic, which is obsessive compulsive disorders. And how we are going to proceed with the presentation is I'll be giving a brief introduction and then talking through the etiological factors, the clinical features, how to diagnose, what are the comorbid conditions in OCD, When we talk about differential diagnosis, what are the dilemmas, and then how is the course, the treatment, the prognostic factors. Just a brief note about OCD spectrum disorders as well. And then we'll have few sample exercises in the form of case vignettes, and then it will be open for discussion. So coming to the introduction, so basically, obsessive compulsive disorder, so it belongs to a group of disorders under anxiety disorder per se. So it belongs to a group of disorders in psychiatry known as neurosis, wherein touch with reality is maintained. So there is no reality disturbance that is present in neurotic group of disorders. Mainly, it is characterized by what we call as obsessions and compulsions. So they are the central feature of OCD, the presence of obsessions and compulsions. What exactly are obsessions and what are compulsions? That we're going to be seeing a little later. When we talk about epidemiological factors and prevalence rates, so in community studies, it ranges from around 1 to 1.8%. In India itself, according to the National Mental Health Survey, so the prevalence has been found that it is around 0.76%. And OCD is a condition which is not very uncommon in children as well. So we do have children presenting to our clinics with obsessive compulsive symptoms with a prevalence of 1%. When we talk about gender distribution, females have slightly higher prevalence when it comes to adulthood, but whenever we see child cases of OCD, males have had a higher prevalence. And the mean age of onset is around 20 years. Sometimes by 1 or 2 years, it can be a little earlier in men as well. Let's talk about etiology. So in psychiatry, with respect to any condition for that matter, we divide etiology into biopsychosocial model. So there are biological factors that are operating, there are psychological factors that are operating, and there are social factors that are operating. So what are the biological factors when it comes to OCD? So we all know that genetics is something which is very important in psychiatric conditions. So even in OCD as well, there is a strong genetic risk with higher monozygotic concordance rate, meaning to say that monozygotic twins have higher chances of having OCD, around 50 to 80% is the risk that we say, compared to dizygotic twins or other sibling pairs. And it has also been observed that higher rates of OCD is seen in family members of patients with OCD compared to other normal controls. Then when we talk about neurobiological factors, so what are the brain areas that are involved here? So mainly it is the corticostriatal thalamic cortical circuit. So that is the CSTC circuit that is involved. So when I say cortex, I refer to the orbitofrontal cortex in the prefrontal cortex area. And of course, it goes to the striatum from that, and then the thalamus is involved, and then back to cortex. So this circuit or this loop is something which is very commonly involved in certain automated behaviors. So whenever there's a dysfunction here, there is excessive behaviors. So we do find that there is a lot of conjunction between OC symptoms and sometimes certain involuntary movements as well. So that is why this particular track becomes important here. And across neuroimaging studies, it has also been found that there is bilateral small caudate nucleus that has been attributed. So these are some of the neurobiological considerations. Then what are the neurotransmitters that are involved in OCD? So serotonergic, dopaminergic, glutamatergic, and GABA systems are all involved. But mainly for your understanding, you need to remember that serotonin as a neurotransmitter is very significantly involved. And usually we have reduction or reduced levels of serotonin in OCD. Then what are certain immunological aspects here? What happens is sometimes there are certain autoantibodies which are formed against various aspects of basal ganglia. So the evidence for this is Sydenham chorea, which is a feature in rheumatic fever. So here we do find some OC symptoms as well. So here what is happening is there are autoantibodies that are formed against some part of basal ganglia and thereby leading to certain movement disturbances as well as certain OC symptoms. So that was basically the biological factors that are operating in OCD. Then what are the psychological factors? So under psychological factors, we have something known as the behavioral theory. So what is this behavioral theory? It is basically a learning theory, which says that obsession develops whenever there's a neutral object or a thought, which gets paired with a object or event which causes anxiety. Say, for example, you have a person who has normal hygienic concerns in the form of, your hands need to be clean. So before eating or before engaging any other activity, you need to wash your hands. So this is the normal hygienic practice that a person follows. Say, for example, he observes one of his friends who had food poisoning. And then later on, there is a neutral object or a thought saying that, hands, if they are dirty, it will always and invariably lead to food poisoning, which leads to excessive hand washing. So this is the learning theory operating here, wherein a neutral stimuli like, hands being clean is being linked to a object or event which has caused anxiety. Similarly, compulsions develop when the person discovers that certain actions can reduce anxiety caused by obsessional thoughts. What do I mean by that? So he discovers that, okay, if at all I do not use public washrooms, or if at all I do not eat outside, then me developing a food poisoning will be quite minimal. So there'll be avoidance behaviors, or whenever a person feels that, his hands are dirty, he goes on repeatedly washing hands. So what happens when he repeatedly washes hands, or when he resorts to this avoidance behavior, there is reduction in anxiety. So this will go on reinforcing the more and more he does it. And that is why compulsions will become strong. So this is the basis for obsessions and compulsions, taking into inspiration from the learning theory principles. Then we do have what is known as the cognitive theory. So what does the cognitive theory say? Basically, whatever obsessions and the thoughts that are present, so they are cognitive distortions, meaning to say they are dysfunctional thoughts. And usually whenever there is a dysfunctional thought like this, it leads to an unpleasant effect in the form of anxiety, and then it leads to certain behaviors. It could be compulsion, it could be any other problematic behavior. So this is a loop that is forming here. So this is the base for your cognitive behavioral therapy, that there are dysfunctional thoughts that you need to target. So if you target the dysfunctional thoughts, it leads to improvement in terms of even anxiety, and improvement in terms of even problematic behaviors coming down. So that is the core of cognitive behavioral therapy, wherein there are dysfunctional thoughts or negative automatic thoughts. Then we also have certain psychodynamic factors operating. So what are psychodynamic factors? According to Sigmund Freud, so he gave what is known as the psychosexual stages. And he said that either fixation or regression from Oedipal phase to the anal phase during the psychosexual development is what is happening in OCD. So there are certain psychosexual stages, like there is oral stage, and then you have the anal stage, and then you have the phallic stage, and the latent stage, and the genital stage. So what happens in OCD is there is fixation at the stage of anal stage, and the conflict is not resolved at this particular stage, which leads to development of OC symptoms later on. So this is one of the contribution by Sigmund Freud. Another mechanism that is operating in OCD is the presence of certain defense mechanisms. So what do I mean by defense mechanisms? Defense mechanisms are basically defenses that our body has developed in order to fight certain situations which bring in anxiety. So there are certain situations, or there are certain thoughts or impulses which are very anxiety provoking to our ego or to our self. In order to relieve anxiety, in order to make sure that these situations or these thoughts or impulses remain in the unconscious and they do not come to the conscious awareness, certain defense mechanisms will be operating. So for different psychiatric conditions, we have different defense mechanisms that are operating. In OCD per se, we have reaction formation, we have isolation affect, and undoing. So these are three important things that are operating in OCD. So what happens in undoing is that there is a thought or an impulse which brings in anxiety. So what defense develops is that there is something which is opposite happening, in the sense that they engage in certain compulsive behaviors in order to undo the anxiety that is associated with that particular thought or impulse. So that is what happens in undoing. So what is isolation of affect? So you have a thought or an idea and an associated emotion with it. So usually it is anxiety that is associated with the thought or idea. So in isolation of affect, what happens is there is cut off of the emotion from the idea per se. So the idea persists, whereas the emotion part is cut off so that the anxiety is relieved. So that is isolation of affect. Then you have something known as the reaction formation, wherein you have an unconscious impulse. Say, for example, you have an unconscious impulse or a desire when things are messy. So the defense operates in such a way. So this is not acceptable to the ego. This is not acceptable to the self. So the reaction formation is when something completely opposite develops, as in you become excessively clean. You become excessively preoccupied with orderliness and cleanliness. So this is what is known by reaction formation. So these are few defense mechanisms that operate in OCD. Then we do have some mentions about attachment as well, wherein in early relationships, if the emotional attachment is found to be little less or found to be disruptive, then what happens? There is a false sense of security that happens due to various other things. So that is where you get obsessed over, or you get attached to certain ideas, thoughts, or impulses later on. So these are certain psychodynamic factors that are operating in OCD. So we learned what is OCD. We learned about the etiological factors that are operating in OCD. Now let's see what are the clinical features of OCD. So I mentioned initially that central to OCD is the presence of obsessions and compulsions. So what do I mean by obsessions? Obsessions are recurrent and intrusive. It could be thoughts, it could be images, or it could be impulses. And the individual recognizes them as own. They are absurd, senseless, and irrational. They are distressing, and the person tries to resist, but that leads to anxiety. So all these bits of information are important for you to classify something as an obsession. So it has to be repeatedly be present. So a person has to be repeatedly get a thought that my hands are dirty. So it is recurrent. And it is intrusive, meaning to say that even if you don't want it, it intrudes into your mind. So it could be a thought, like I said, it could be an image that pops in, or it could be an impulse to do something. This is very important, the next feature, wherein the individual recognizes that these thoughts, images, or impulses are his own. So this is how we differentiate this from certain psychotic phenomenon, wherein you have something known as the thought insertion, wherein you feel that somebody is inserting, an external agency is inserting their own thoughts into you. But OCD is different because the individual is recognizing that these thoughts are my own thoughts. And the third point is again very important. It is ego dystonic. That is, you do not want it. Your ego does not want it. It is termed as absurd. It is not necessary for me to get these thoughts. It is senseless and it is irrational, but still there is no control. So that is what I mean by ego dystonicity, wherein you do not want these kind of experiences. And it is quite distressing to the person as well. And some amount of resistance in order to not get these thoughts. They develop their own techniques to try and resist. But usually whenever they try to resist it, it leads to anxiety. Obsessions we can divide in terms of form due to various, in terms of various factors. So based on form, we have obsessive thoughts. These are words, ideas, or beliefs which the patient recognizes as his own, and they intrude forcibly into the mind. Like I said, they're very intrusive, and they may take the form of even single words, phrases, or rhymes. So these are under the heading of thoughts. Then we have something known as obsessive doubt. So here you have repeated themes which express uncertainty about previous actions. So for example, a person feels that whether he has switched off an electrical appliance or not, whether he has locked the door or not. So these are doubts. Then we have something known as rituals. So these are mental activities and which are repeated but senseless behaviors. Some rituals may have an understandable connection with certain obsessional thoughts that precede them, whereas some do not have a connection at all. Say, for example, a person feels compelled to repeat such actions a certain number of times. So there are, if the sequence is interrupted, it has to be repeated from the beginning. Say, for example, a person is dressing and then he feels that he should always start from the right side. And then if at all that pattern is disrupted, then it leads to him starting all over again. So this is what is meant by obsessional rituals. Then we have something known as obsessive ruminations. So these are internal debates in which there are arguments for and against. Even simplest day-to-day actions are reviewed endlessly. So it could be about very basic things, something doubts about the world, when does the world end, or certain metaphysical thoughts like this. And they achieve no conclusion, but there are internal debates and arguments for and against these thoughts. And then we have something known as obsessive image. So these are images of violent, sexual, or disgusting nature that can come repeatedly into the mind. It could be very everyday basic images as well. So we have ruminations, we have images, we have rituals, thoughts, doubts. Then we have obsessive phobias as well, wherein it is associated with avoidance and anxiety. So you get repeated impulse to injure another person. So that leads to avoiding certain situations or certain people. So these are obsessive phobias. Then, like I said, impulse, repeated urges to carry out actions which are usually aggressive, dangerous, or socially embarrassing. So these are various forms of obsessions that are present. Then what are the content of obsessions? So sexual content is quite often seen, wherein there can be sexual advances towards self or others, certain masturbation practices, incest. So all these could be content of obsessions. There could be certain religious content as well. Regarding God, regarding certain mythological stories. Sometimes they do get blasphemous thoughts. that is swear words against God or imagining God with certain objects such as slippers or something which is very disturbing. So those are known as blasphemous thoughts. Then there can be content can be aggression as well. So physical or verbal assault on self or others, accidents, deaths. So all this could also be the content of obsessions. Dirt and contamination is something which is very commonly seen. It could be dirt, dust, menstrual blood, human or animal excreta, something like that. And the content can be very inanimate and impersonal as well. So mathematical figures, orderliness, certain arrangements, tasks, locks, bolts, mechanical or electronic devices. So all these form the content of obsessions. So we saw what was obsession. Now what is a compulsion? So a compulsion is a behavior or a mental act that usually follows obsession, and it usually relieves anxiety. And this again, along with obsession, this is ego dystonic. So the person feels that it is not required, but still he's not able to control. So compulsions are always aimed at relieving anxiety. How do they relieve anxiety? So again, we have two types of compulsions, the forms of compulsions. One is yielding compulsion, wherein a compulsive act will give expression to the underlying obsessive urge or thought. Say, for example, you have a person who has an obsessive doubt that he has an important document in one of his pockets, and he is compelled to check his pockets again and again. He checks once, he's satisfied, and then again he gets this doubt, and then he checks again. So it becomes repetitive like that. So here the compulsion is giving expression to the underlying obsession. So this is yielding compulsion. So by doing that, what is essentially happening is anxiety is getting relieved. Then we have something known as the controlling compulsion. So here the compulsive act will tend to ward off and divert the underlying obsession without giving expression to it. Say, for example, you have a boy with sexual impulses or thoughts as an obsession. So to control anxiety related to that, he repeatedly and loudly counts to 10. So he's doing some other activity as a distraction from the underlying obsession. So it's not giving expression to the obsession, but acting as a distracting measure. So this is a controlling compulsion. So these are two types of compulsion, and basically compulsions are always aimed at reducing anxiety that is associated with the obsession. Then we have certain special types of symptoms in OCD as well. There is obsessional music. So here patients experience repetitive phrases. There could be tunes or certain jingles. Popular advertisement jingles are also heard, and they have been described from Indian centers as well. These are all very rare. Then you have something known as obsessional rehearsal, where sometimes when they engage in and then it feels very odd and eccentric. So they rehearse these sort of compulsions to make them look very normal. So that is another special symptom that is seen in OCD. And then you have masked obsessions. So here they appear in disguised or masked form. Say, for example, pain could be a masked obsession. So they come repeatedly to the clinics with symptoms of pain, but then conventional treatment will not be effective. Once you dig in and then you do a detailed interview, you tend to identify that there is usually a obsessional quality for the pain per se. So these are known as masked obsessions. Then another special type is contradictory thinking. So here, whatever thought that you're supposed to get, you get the opposite of that. Say, for example, a person prays, do good to me. So do bad to me is something which comes automatically to the patient's mind. So this is contradictory thinking. Then we have another type of special symptom in OCD, which is known as the ROCD or the relationship OCD. So here there are doubts and preoccupations which are centered on the perceived suitability of the relationship. So it is very relationship centered or partnered focused. So the kind of doubts that the person gets is he the right person for me? Or they could also get images, the face of the relationship partner, or they could have urges or impulses to leave a person's partner. So compulsive behaviors can also be accompanied with these kind of obsessions, wherein they monitor their own feelings. Do I really love this person? Or they compare with other potential partners, or they neutralize, and sometimes they seek a lot of reassurance as well. They may sometimes start doubting the fidelity of their partner, despite being aware that it is not so. So this is an important factor here, wherein they know that their partner is faithful to them, but they may get doubts that they are not faithful to them. So this is a special type of symptom which is seen in OCD, which is the relationship OCD or the ROCD. Then we have something known as the family accommodation. Usually this is seen in children, wherein they rely on their caregivers for both physical and emotional needs. So OCD, when it develops in children, certain compulsive behaviors they may not be able to do on their own. or certain situations which are, very anxiety provoking, their family and their environment will accommodate in such a way that anxiety is reduced in the child. Say they can impose rules and prohibitions on family members. They can involve family members in compulsive rituals, in doing their compulsions, or demand to perform actions instead of the child, or refrain from certain behaviors to avoid distress to the child. So this is family accommodation. Then another very commonly seen symptom in OCD is what we call as magical thinking. So the basis of this is there is a certain thought, it leads to action. If I just get this thought, it will actually happen. So that is known as magical thinking. So they believe that merely thinking something will actually happen in real. For example, a person thinks that if I do not knock on the door 4 times, the house will catch fire. So every time he enters the house, he knocks on the door 4 times. So that is the thought action fusion that is happening there, wherein he feels that if he doesn't knock, the house will catch on fire. So this is magical thinking, which is most commonly seen in many patients with OCD. So that is about obsessions, that is about compulsions, that is about certain special symptoms that are present in OCD. Then what are the patterns in OCD like? So contamination is the most common pattern or the theme that we observe, wherein obsession about contamination. So you get repeated thoughts that hands are dirty, body is unclean, household objects are dirty. And then the underlying compulsion is to clean. Then the next symptom pattern is pathological doubt. So this is the second most common OCD pattern that we see, wherein there is obsession of doubt, whether the door is locked or not, whether the stove is switched off or not. And then there is compulsion of checking it. Then you have pure obsession. So this is the third most common, wherein there are just obsessions without any compulsions. So like I mentioned, content of religious thoughts or images or sexual or aggressive obsessions can be present. Then we have symmetry. So there is extreme need for symmetry or precision. So you feel that the books have to be arranged in a particular order itself. The stationary items on the table should be kept in a particular angle or kept in a particular place itself. All this is associated with compulsive slowing, because when there is extreme need for symmetry or precision, whatever the task that you have to do invariably gets slower. So that is compulsive slowing. So these are certain symptom patterns in OCD. So we saw a lot of symptoms that are present in obsessive and compulsive disorder. How do we diagnose OCD? According to ICD-10, so the code that is given to OCD is F42. It is characterized by obsessions or compulsions or both. So it need not be that both have to be present. So either obsessions can be present or just compulsions can be present, or both of them can be present. It should be present for most days for at least 2 weeks, and it should cause significant distress to the person, and of course lead to socio-occupational dysfunction. Along with this, it should not be due to any other substance. It should not be explainable by any other psychiatric condition. So all of these characters, if they are present, then you can make a diagnosis of OCD. Then what are the comorbid conditions in OCD? So depression is something which is very common comorbid condition associated with OCD. So you'll be talking, Dr. Kshama is going to be talking later on about depression. So there can be secondary depression in patients who have OCD as well, and other anxiety disorders. Yesterday you've had a class. So panic disorder or generalized anxiety disorder or other specific phobias can coexist with OCD as well. Tic disorder is something which is very commonly comorbid with OCD. So like I mentioned, if at all you can recall the neurobiological aspects and the track that is involved, the CSTC track. So it involves certain involuntary movements as well. So that is how tic is commonly comorbid with OCD. Then we can have what is known as obsessive compulsive personality disorder. So this obsessive compulsive personality disorder, the central feature to this is all symptoms, whatever I described in OCD, are present here. But the only differentiating feature is that it is ego-syntonic in obsessive compulsive personality disorder. That means that it is in sync with the ego. So it is not distressing to the patient. The patient does not feel that, these thoughts or these behaviors are not required. So he feels that it is very much required. So that is the differentiating feature between obsessive compulsive personality disorder and OCD. That is, it is ego-syntonic in obsessive compulsive personality disorder, whereas ego-dystonic in OCD. Then we have a condition known as PANDAS. So it stands for pediatric autoimmune neuropsychiatric disorder associated with streptococcal infection. So here what happens is you have certain OCD symptoms in children, which are precipitated or worsened after infection with group A beta hemolytic streptococci. So what happens is whenever there's an infection, it triggers an autoimmune response in the basal ganglia, and that leads to development of tics and OCD-like symptoms. So this is something which is very important, and in certain children, whenever they present with OC symptoms, this is something that should also be kept in mind. Then coming to the differential diagnosis. So what can we confuse OCD with? So yesterday there was a class on anxiety disorders. So other anxiety disorders can also be presenting sometimes like OCD. So you have generalized anxiety disorder. Here also there can be repetitive thoughts, but how it is differentiated from OCD is that here there are excessive worries about real life concerns, and compulsions are something which are not seen in generalized anxiety disorder. So there are a lot of worries here. So that is how it is differentiated from OCD. And in depression as well, you have something known as ruminations. So they are meaningless chain of thought. But again, the content of this is mood congruent, meaning to say that mood is significantly low, mood is significantly depressed, along with these ruminations. And of course, it is not ego dystonic. The person does not feel that it is not required. So ego dystonicity is something which is a very central feature for OCD, and that helps you to differentiate OCD from other psychiatric conditions. Then certain psychotic disorders can also, you can have some sort of doubt when it comes to OCD, but the presence of delusions and hallucinations. So if that is there, then it goes more in favor of psychosis. OCD also sometimes when it is very severe, they may lose insight. Insight is they have insight into their symptoms that, they are absurd, irrational, they're not required. But if at all it is too severe, the insight can not be there, and that can lead to presence of delusions, and then there is a psychotic component to your OCD. So that is also something which can happen. Then of course, neurological disorders. So I mentioned the brain areas that are responsible here. So if at all they are involved, so if you're seeing late onset of symptoms, somebody is developing OC symptoms after 50 years, 60 years, whereas I described that the typical age of onset is in their 20s. And there is abrupt onset of symptoms. So you have onset of symptoms very abruptly. So they are completely okay today, and then within a span of days or a couple of weeks, they have full-blown OCD symptoms. And there is poor response to your conventional treatment. So you are giving your SSRIs, you're giving your treatment, and the OCD is not getting better. And they are accompanied by other neurological signs and symptoms. So it could be certain involuntary movements that are present, or other neurological signs and symptoms. If they are present, you need to think that it could be an organic disorder here, and then you need to work in terms of that and not in terms of an OCD. Then, like I said, tic disorders. Sometimes complex tics may be similar to compulsions. But what is the essential feature that has to be remembered here is tics are usually preceded by sensory urges, whereas compulsions, a compulsion to do something, is preceded by the thought or the obsession. So that is something which differentiates tics from compulsions. Then what is the course of OCD like? So it is a chronic waxing and waning condition. It is usually seen that around 20 to 30% of them have significant improvement in their symptoms, almost full improvement. Then around 40 to 50% may have moderate improvement with some symptoms that are still there. And even in cases who do improve, another 20 to 40% may have, another 40 to 50% may have a relapse as well. And you have this 20 to 40% of people who go into the category of very severe treatment resistance, or there is further deterioration, who show very minimal improvement. So this is usually the course. Another thing what is very important to remember here is there are usually certain precipitating factors or certain triggers. A person has a predisposition to develop OCD, but then when he develops OCD is when sometimes he's going through a stressful situation, or there is some physical deterioration in his health. So any of these triggers can set off OCD symptoms, or a person who is doing well and who has gotten better can later have relapse whenever there are triggers like this. So then coming to the assessment. So how do we assess for presence of OCD? One is a detailed clinical interview. Like I said, sometimes it is very difficult to establish whether a person has an obsession or a compulsion. It could be masked by other symptoms, or you could be confused by other anxiety disorders. So a detailed clinical interview is going to help in this regard. You may have to do routine blood investigations. Neuroimaging is required, like I said, whenever you are suspecting an organic component. So late onset of symptoms and not responding to your typical drugs. So that is when you consider neuroimaging, which can be done as well. And psychological assessment, we do have certain scales to assess the severity or the presence of OCD symptoms. One very commonly used instrument is the Yale-Brown Obsessive Compulsive Scale, so the YBOX. We have other inventories as well, that is Obsessive Compulsive Inventory, that is OCIR, and then you have something known as the PADWA inventory. So Yale-Brown Obsessive Compulsive Scale, this is the gold standard for measuring OCD severity. It rates time, interference, distress, resistance, and control for obsessions and compulsions. So there are two components in YBOX scale. One is wherein it is a checklist of what obsessive symptoms are present and what compulsive behaviors are present. And then you have another part of it wherein it rates how severe is the OCD. So there are 10 items. So the score ranges from 0 to 40. So if it is less than 7, it is subclinical. 8 to 15, very mild symptoms are present. 16 to 23 being moderate. 24 to 31 is severe, and 30 to 40 is very severe or extreme form of OCD. So we have talked about what is OCD, about the etiological factors, about the clinical features, how do we diagnose, how do we assess, what is the course that we expect in OCD. Now, how do we treat OCD? So treatment considers consists of two things. One is pharmacotherapy and one is psychotherapy or non-pharmacological approaches. So in pharmacotherapy, mainly it is the antidepressants, the selective serotonin reuptake inhibitors that we use, SSRIs. So whatever I put in the bracket, the dose, so that is almost towards the maximum dose. It is not the minimum or the optimal dose, it's the maximum dose. Fluoxetine up to a maximum dose of 80 mg, sertraline up to 200 mg, escitalopram up to 30 mg. So these are few very common SSRIs that we use in the treatment of OCD. One thing that a general rule that we need to remember in terms of treatment for OCD is that the treatment is required for a longer period of time and the medications are required in higher doses as well. Say, for example, you're using fluoxetine 40 mg, 60 mg in other anxiety disorders or in depression. For treating OCD, you require higher doses, that is up to almost the maximal dose, 80 mg. And even to assess for the remission of symptoms or whether the symptoms are getting better as well, you need to give it a longer period of time. So before you adjust the dose, before you feel that it is not working, I have to change the medication, you need to give an extended period of time. If you wait for 4 weeks in case of other anxiety disorders, here you may have to wait for 6 to 8 weeks before making any sort of changes with respect to medications. Then we have another group, that is the tricyclic antidepressants or the TCS. Here clomipramine is something which has found a lot of evidence for OCD. Again, in the ranges of 200 to 300 mg, we may use depending upon whether the patient is able to tolerate it, because the adverse effect profile of TCS is severe compared to SSRIs. They may have a lot of sedation. They may have a lot of anticholinergic side effects wherein they may not be able to tolerate the medications. So these serotonergic agents, around 50 to 70% of patients respond to the treatment. If at all only partial results are seen, sometimes we do augment with antipsychotics. So we keep the antidepressant going and then along with it a very low dose of antipsychotic in the form of quetiapine or risperidone and olanzapine can also be used. And benzodiazepines are sometimes used as short-term anxiolytics. You start the patient on an antidepressant, so you'll have to wait for some time until the OC symptoms get better. So until then, there is a lot of distress, there is a lot of anxiety. So to counteract that, benzodiazepines can be used. And usually we continue treatment for 6 months to a year. That is, even if they do get better and it is the first episode, we continue treatment till a year almost and then taper and stop. And further, if at all they develop symptoms again that has to be, the process has to be followed. So psychotherapy, so what are certain psychotherapeutic approaches for OCD? So you have cognitive behavioral therapy. So I told you in when I was talking about etiology with respect to psychological factors, that there are certain cognitive distortions or there are certain negative automatic thoughts that are present in OCD. So if we target these thoughts, then the effect is going to get better and the behavior, the problematic behaviors, whatever is there, that is going to get sorted. So cognitive behavioral therapy is based on those principles that the thoughts are dysfunctional. Then another form of cognitive behavioral therapy, which is almost the gold standard we can say in OCD, is exposure and response prevention. So what is happening in exposure and response prevention is that in simulated conditions, we are exposing the patient to the obsessive thoughts or doubts or whatever content of obsessions that they have, and then we are preventing them from forming a response. Say, for example, in an OPD setup, and whatever the triggers that we are giving in terms of exposure, so that will happen in a graded manner. So if at all, for example, he has obsessional thoughts that his hands are dirty, so initially we start talking about things that are dirty, and sometimes we may have to show them images as well, or sometimes in vivo setting wherein they are exposed to a setup wherein there is a lot of dirt. So that is the exposure that I'm talking about, which goes in a graded manner. And the whole point is to prevent response. So he should not wash hands. So there should not be any compulsion following this trigger that you are giving. So this is the basis of exposure and response prevention. And that if it is practiced in real world setting as well for a continuous period of time, then that leads to improvement. Then we have certain thought stopping techniques as well. So we teach our patients that whenever they do get these obsessive thought or doubts, so they have to yell the word stop loudly, or they have to imagine a stop sign. So the traffic sign, whatever they see, the stop sign, either they have to imagine that or they have to yell the word stop very loudly. So that initially arrests the train of thought that follows. It is not very easy. They may have to do it repeatedly to find some result. So, but that is one way of doing it. Another way of doing it is wherein we tell them to tie a band over their wrist, and whenever they get these obsessive thoughts, they are supposed to snap the band across the wrist. So that leads to some amount of pain. So you are incorporating a painful response to that obsessive thought, and again that when it is repeated quite a number of times, then it may lead to some amount of improvement. Of course, all these techniques sometimes usually goes along with your pharmacotherapy, because when the distress is very high, when the anxiety is very high, we cannot usually start just the psychotherapeutic techniques. We'll have to give medications to reduce the underlying anxiety, and then further start these techniques as well. Psychodynamic psychotherapy, that is finding less and less evidence, and then it is rarely practiced these days. But this is about all those unconscious conflicts that happen in the childhood. So uncovering that and working through that in order to find relief in today's symptoms. So that is what psychodynamic psychotherapy is all about, which is very rarely practiced these days. There are certain other modalities of treatment as well. Deep brain stimulation in treatment resistant cases. So not all cases that you start your medications and your psychotherapy will improve. Like I said, around 20 to 40% of them are difficult cases which may not improve at all. So deep brain stimulation, that is stimulating certain areas of the brain, certain areas that are involved in OCD per se, can lead to some form of improvement. Electroconvulsive therapy. So ECT is something which we commonly practice in depression with suicidal ideations or in psychotic symptoms. Sometimes when you are left with no option, all your medications are not working, you may give a short course of ECT as well, especially in treatment resistant cases and in cases wherein there is absent insight and they have psychotic symptoms. So that has found some benefit as well. Certain psychosurgeries like cingulotomy and capsulotomy, so these used to be performed previously. Again, according to MHCA, it's not practiced anymore and it is not advisable anymore because they have a lot of complications as well. So that was with respect to the treatment in terms of medications, in terms of psychotherapy techniques, and in terms of other modalities that are present. Then what about the prognosis in case of OCD? So whatever factors that I've described here, so they all lead to bad prognosis. Earlier age of onset of symptoms, that is childhood onset OCD, male gender, having a very chronic course, mixed OCD in the sense that they have obsessions and compulsions, both. Poor social functioning, comorbid tics if they are present, if they have other personality disturbances, if they have other comorbid psychotic symptoms. So all these lead to bad prognosis when it comes to OCD. Then just a brief note about OCD spectrum disorders. So they have certain obsessional qualities, these set of disorders. Again, they're classified in OCD spectrum. So if we consider ICD-11, you have a separate heading, OCD spectrum disorders, under which you have your OCD and all these disorders. Whereas previously in ICD-10, OCD was classified under neurotic and stress-related disorders. So you have body dysmorphic disorder, wherein there is preoccupation with imagined defect in the physical appearance. So my nose is small, my nose is crooked. So it could be imagined or a very minute defect that is present, and there is preoccupation with that. So that is body dysmorphic disorder. Then there can be hoarding disorder, wherein there is inability to discard items that are of little or no value. So it need not be monetary value that we are talking about here. It could be sentimental value as well. So if that is not there, and despite that they are not able to discard certain items, then it can be classified under hoarding disorder. Again, they hoard lot of things like, newspapers, or sometimes we had a patient who used to hoard tablet covers, as in after the tablets are used, the covers, and certain other stuff like that. Then you have trichotillomania. So there is a recurrent or irresistible urge to pull out hair. So that is associated with some form of relief from anxiety when that happens. Then you have olfactory reference disorder. So there is excessive preoccupation that one smells bad. So these are certain conditions which come under OC spectrum, and they have some obsessional quality in their symptoms. So what we'll do now is I have a couple of case scenarios. So we can have someone reading out the case scenario, Prakriti, if that is possible. Somebody can walk
Yes, sir.
here, and then I'll project the case, and then somebody can come up with what the case vignette is all about. Just because I'm talking about OCD, it need not be OCD per se. If anybody can volunteer, then we'll start with the case scenario.
Yes, ma'am. I'll go with that.
Sure. Yeah.
Scenario 1. A 12-year-old boy was brought to by parents with 1 month duration of symptoms. Boy requests school authorities to make repeated phone calls to his father. When refused, he cries excessively. Child reports that he gets repeated images of his father like he was and that they had garlanded his father's photograph. He feels very distressed and compelled to inquire about him immediately. He feels temporarily reassured when he talks to his father.
So anybody can volunteer and tell me what this case is about. Anybody can unmute and talk. Yes, somebody has raised their hand. They can go ahead.
Ma'am, do you want to know what the probable condition could be
Yes.
in this scenario? Okay,
Yes.
is it some unresolved trauma which led to some delusional thinking and behavior where he's thinking something which is deviating from what's normal?
Okay.
A scenario where where he's throwing tantrums, he's refusing because he's imagining things away. So is this some delusional disorder thing?
So you say that it is delusional disorder. Anybody has any other answer?
Fear, ma'am.
Okay. Fear is a very broad thing. Why?
Like if he had any previous traumas, whether he lost his beloved ones and worried about losing his father.
So you are saying that he's worried about losing his father, right? What is the child actually doing? What does he say?
He's getting that repeated
He
images of
mentions
his father.
images of his father.
Yeah, that he had a garlanded his father's
So
photograph.
he got repeated images in his mind that
Anxiety,
his father
certain anxiety
was
disorder.
garlanded, right? So what does that
Yes,
mean?
ma'am.
Anxiety driven psychotic disorder, like anything as such, ma'am.
Okay. Psychotic disorder is when, of course, whatever you're saying, you're trying to think in that direction. But here, considering OCD, can you think of something?
Ma'am, can separation anxiety could be acute stress reaction due to separation
Separation anxiety happens much earlier on. When they're initially separated from their parents. Let's say that this person has started school, and then initially some amount of separation anxiety was there, and after that it resolved. Only since 1 month he's having these symptoms. He wants to call his father repeatedly to make sure that he's okay. And once he talks to his father, he's reassured. But then again, he gets into a mode wherein he requests authorities to make phone call to his father again. And if they
We
refuse,
need
he
to
cries
know the
excessively.
triggering thing for this. Like, if there's any past issue in the last 1 month,
Let's
could
say
be
there is
some
no past
acute.
issue at all. There is no traumatic issue. There is no significant issue in the past.
Ma'am, is it like under a IC10 or DSM criteria case? Like, is it a clear-cut diagnosis or is it?
Yes, it is a clear-cut diagnosis. I mean, at least there are bits to say that it is pointing towards that diagnosis. Okay, so here the child is getting repeated images. What is that?
I think those are like
Halluc-
intrusive thoughts and images that he's
Images, so
getting.
obsessional images. So he's getting it
and
repeatedly.
he has the compulsion to inquire immediately
Yes,
about his father.
exactly. So it is
So
associated with a compulsion wherein he feels that he needs to seek reassurance. He's asking school authorities to call his father. So he gets that obsessive image of his father being garlanded repeatedly, and then that is associated with the compulsion of him seeking reassurance and calling his father repeatedly. And if at all the school authorities refuse this, he cries excessively. So this is the anxiety which is coming out in form of the child crying. So the child cannot tell, right? This is what I'm going through. I'm feeling anxious. So that is how it is presenting. So this is a classical case of childhood OCD. Anybody has any doubt here? So the distress part is there, anxiety is there, the obsessive image is there, and then there is compulsion as well. So like I said, in children, it may not present like typical OCD symptoms that happens in adults. There could be some changes like this. If anybody has any doubt, they can talk. Otherwise, we can move on to the next scenario.
Ma'am, what is the diagnosis finally? Like,
OCD,
what
OCD.
is it?
There
OC,
are
okay.
obsessive images, and there is compulsive behavior in the form of repeatedly calling the father.
Okay, ma'am.
So who wants to volunteer for the next scenario?
I can read it out.
Yeah, sure. Go ahead.
A 34-year-old architect is referred to a clinic by his HR department because his projects are consistently months behind schedule. During the intake, Marcus expresses intense frustration, not being with himself, but with his incomplete colleagues and the sloppy building codes that he is forced to follow. He spends 4 hours every night reviewing his blueprints. He insists that every line must be weighted perfectly and every calculation checked against 3 different mathematical models. When asked if these checks made him anxious, he looked puzzled. Anxious? No, he replied. I do it because it's the only correct way to do it. If I don't, the integrity of the profession is compromised.
Yes. Can anybody tell what could be the diagnosis here? Yes, there are 2 people who have raised their hands. Yes, Gaurav. You can go ahead and answer. Okay. Anybody else wants to volunteer? Yes, Prakriti.
Mom, I think this is, again, it fits obsessive compulsive personality disorder, I believe, because it has the egocentric perfectionism component to it. which
Yes.
I think is delaying the work at hand.
Yes, excellent. So she says that this is obsessive compulsive personality disorder. Although when you read the case summary, you feel like there are certain obsessive symptoms wherein he feels every line should be weighted perfectly, every calculation should be checked against three different mathematical models, and there is lot of delay in the work that is happening. So all these sometimes you feel that okay, there are some obsessive symptoms that are present. But the differentiating feature here is when they ask him, does that make you anxious? When you do all these things, do you feel that it is necessary to do it? He says that anxious, no, I do it because it is the only correct way to do it. So there is no anxiety component here. When there is no distress, when there is no anxiety, and then it is in sync with the ego, it becomes obsessive compulsive personality disorder and not OCD. If at all it were to be OCD, it would be associated with a lot of anxiety, and then of course he has not come to the consultation on his own. So he was referred by his HR department, and he even says that I am here because my other colleagues are incompetent, not because I have a problem. So that goes more in favor of an obsessive compulsive personality disorder. Right? Any doubts here? So can we move on to the next scenario? Who wants to volunteer?
Ma'am, I'll volunteer.
Sure. Yes.
Scenario 3. Patient David, a 42-year-old father of two, presenting problems, chronic fatigue, brain fog, and a constant inability to turn off his brain, particularly at night. David reports that he cannot leave his house without a 15-minute safety sweep. He checks the stove, the toaster, the hair straightener, and the backyard gate. He says, I am just worried that if I'm careless, the house could catch fire and we'd lose our insurance. Then we'd be homeless. And the kids' lives would be ruined. It's just everything feels like it could go wrong at any second.
Okay. Anybody wants to volunteer? What is the diagnosis here? Or at least what is it inching towards?
OCD, ma'am, because of the anxiety component you
Okay,
mentioned.
there is anxiety, that is fine. What is not going in favor of OCD here? Although he's checking the stove, toaster, or other appliances, what do
He's
they
not
talk?
repeat. He's not repeating
Comfort.
the same thing again, ma'am.
Yes, so he checks once and then he moves on to the next thing. And they've even described a timeline of 15 minutes. So usually obsessions take a lot of time. So there is multiple checking and then multiple compulsive behaviors. So he does a very quick 15-minute safety sweep here. But then some anxiety is there, is something that we have established. So what could it be leading towards? He says he's worried.
Can it be compulsive act but not ego synced or ego distorted? Because I don't think like that's something which he wants to be doing it. But
If
like
it's ego dystonic, again, it goes more in favor of OCD.
okay.
Look at the explanation that he's giving for those checks. So there's a lot of things that he's saying. If I don't do that and I'm careless, the house could catch fire. Then we would lose our insurance. Then we'd be homeless. Then it would affect our kids' lives. Everything will be ruined. So there's anxiety, which is involving a lot of spheres of his life.
Ma'am, could it be generalized anxiety
Yes,
disorder
exactly.
by
It
any
is
chance?
generalized anxiety disorder. So there is free floating anxiety here. It's not restricted to your obsessions or compulsions. If I don't do this, this could happen. So there is frequently there is changing in his symptom pattern. So it is involving most of the domains in his life. So it goes more in favor of an anxiety disorder, a generalized anxiety disorder at that.
Ma'am, I
Although,
had a query.
yes.
Um, isn't general anxiety disorder more like of a timeline basis of 6 months or more and a
Hmm.
lot of different things
Hmm.
and accompanied by them like these of course this chronic fatigue and all that, but If you need to classify it as a GAD, it should be more than 6 months, and you know, a lot of things, other aspects in life also getting affected, and then
Yeah.
feeling.
So I've not
Um,
mentioned the timeline here. I'm just telling that,
okay,
it could inch towards that rather than an OCD. Of
okay,
course, it requires 6 months, and then there are everyday problems. So that is what they fret about. That is what there is free flowing anxiety. Worrying is something which is a component of generalized anxiety disorder. So I'm not saying that it is diagnostic of GAD, it is inching towards that. More than
yes,
your OCD, it is going in favor of your generalized anxiety disorder. There are other symptoms. Of course, there can be your autonomic symptoms as well, physical symptoms as well, and other mood symptoms could also be present for a duration of 6 months. All that is there. But then, in terms of differentiating the OC quality here that he's checking, so you should not get carried away that whenever you see something like this, it has to be OCD. So you need to try and think and ask more questions. This could be a real patient itself. So you need to ask more questions in order to bring out the OC quality here. That is what I'm trying to stress. Right. So those were the scenarios. We have come to the end of the presentation. Any questions?
Yes, ma'am. I have a doubt.
Yeah. Please
See,
introduce yourself.
during the pharmacology, you have mentioned three major drugs. One is sertraline, the
Hmm.
escitalopram, and the third one. So,
Hmm.
based on the patient's condition, I mean, like we can't give the same drug to everyone, right?
Hmm.
So, I mean, based on the patient's, I mean, what do you consider the factors like the coexisting conditions or the associated other associated psychological disorders that you suggest these kind of drugs to that patient?
So SSRIs are the first line of management for OCD, for anxiety disorders per se. Again, among SSRIs, which SSRI to choose, I've put across these three medications because they're very specifically, they act against OCD. The literature says that way. But sometimes we do consider a lot of factors, like if there is a particular adverse effect that we want to avoid. Say, for example, in your baseline check, you have found out that the person has sexual dysfunction, and SSRIs are known to exacerbate or cause sexual dysfunctions on their own. So at that point of time, you try and avoid SSRIs and you think of a TCA for that patient. Say, for example, that person has constipation, that person has blurring of vision. So if you give a TCA to such a person, then it will lead to increase in the anticholinergic symptoms. So it is about two things whenever we are choosing a medication. One is what effect that we are trying to achieve. And then the second part is what side effect we do not want in this patient. So considering his other clinical aspects, we do make a choice. But usually SSRIs are the first choice when it comes to OCD. Escitalopram and fluoxetine, that is something we commonly use. Anything else?
Also, ma'am,
Hmm.
there's another doubt I have to have.
Yes.
I've heard about the psychological triad before.
Hmm.
So, do you get to see these patients in who has OCD, or is it just an whole another scenario altogether?
You mean the Beck's triad, is it? Hopelessness, helplessness, and worthlessness?
That as well as the other triad, ma'am, especially the personality triad. When it comes to obsessive
Hmm.
compulsive personality disorder, right?
Hmm.
So, do they associate with any other personality disorders, especially the triad, the dark triad of psychology, that is?
So you're saying that obsessive compulsive personality disorder, can they have other personality traits as well? So what is
Yes.
the trait that you're talking about? So
That is
uh,
narcissism,
hmm,
Machiavellianism, and psychopathy.
okay. So all this belong to your cluster B. there could be traits of multiple personality disorders. It does not mean that, if a person has obsessive compulsive personality disorder or traits belonging to that, he cannot have traits of other clusters. He can have narcissistic clusters as well, wherein there is an inflated self-esteem, and then he could have certain traits from cluster A as well, wherein he is very paranoid, he does not trust others. So there could be a combination of traits that could be present in a person, but predominant, what are the traits that we are seeing, that will tell you whether this is the personality disorder that is predominating. Again, it could not be to the level of disorder as well. Sometimes you can have traits across different personality clusters. But according to your ICD, again, certain number of criteria should be fulfilled. So if that is fulfilling, then you do go ahead and make a diagnosis that this person has this personality disorder, or he can have multiple personality disorders as well at the same time. That is quite possible. Anything else? Anybody has come across any
Ma'am,
patient?
I have one more question.
Yeah.
Ma'am, there is a saying that OCD cannot be cured without treatment. Is it true? What's your perspective on this?
Sometimes OC symptoms, they naturally remit as well. Any psychiatric illness for that matter, there is a natural course wherein the symptoms sometimes do get better without you doing anything. So certain patients have this as well. Of course, with treatment, the distress part is reduced, and then we can achieve remission much quicker. But naturally also, there can be remission without even initiating any treatment. That can happen as well. So it does not mean that without treatment it is going to go on for long. Sometimes we do expect a natural remission as well.
Okay, ma'am. Thank you.
Ma'am, I have one doubt.
Yes.
Regarding the third case scenario, why can the diagnosis not be paranoia?
Third case scenario.
Yes, ma'am,
Okay. Why do you feel
where
that
he
it's
was,
paranoia?
ma'am, he was paranoid about the house catching fire and if the
Hmm.
doors are locked or
Hmm.
anything like that.
Hmm. Okay. So when
Mm.
the treating psychiatrist asked him, why do you feel that you have to do this safety checks? What did he say?
Uh, Ma'am, can you show the case? Sorry.
So what does he say here? He says that.
He's just worried that
Hmm.
he would lose everything.
Hmm.
Um, yes, ma'am. He's just bad about losing everything and everything going wrong.
Okay. Is there a possibility that it can happen? Whatever he's saying.
Uh, Not really, but yeah.
If at all he has not switched off the stove, the house could catch fire, and then they
Hmm.
lose their insurance, they would be homeless, and then the kids' lives would be ruined. So there is a possible
Hmm.
explanation here, right?
Yes, ma'am.
So he's worried that it could happen. Paranoia
Oh.
usually has those experiences which you cannot try and associate. It may not be able to say that there is a causation that is happening there. Or it usually involves other spheres, not being able to trust other people. Whatever neutral acts that you find from people, you feel that they are doing it to, get back at you or cause you some form of harm. So it is usually directed to others in that sense. So this his own actions, he's saying that if I don't do this, this could happen, and then that could happen, and then everything could be ruined, everything could go wrong. So that is the anxiety component here rather than the paranoia.
Okay, ma'am. Thank you, ma'am.
Yes.
If there are any questions, please do put forward in the chat box. I hope that's it. With that, I thank you, Dr. Vatsalya Gowda, for that highly informative and engaging session. Your clear explanation of the clinical features, the underlying mechanisms, the evidence-based management, along with clinical vignettes, has truly enhanced our understanding of this complex and often unrecognized condition. We sincerely appreciate the depth you've brought into this session and the perspectives you've shared with us today. With that, I shall introduce our next speaker for the day. So the next speaker for the day is Dr. Kshama H.G. Dr. Sharma is an associate professor in the Department of Psychiatry at Kempegowda Institute of Medical Sciences. She holds an MBBS degree and an MD in psychiatry and brings her with over 9 years of dedicated teaching, contributing significantly to undergraduate and postgraduate medical education. In addition to her academic role, she serves as an advisor for the Fulbright medical student through the KTGF Foundation in collaboration with the Stanford University in 2022, reflecting her engagement with global academic initiatives. Her areas of interest include medical education, public health, and de-addiction medicine. Today, she'll be speaking with us on depressive disorders, an area of immense clinical and public health importance. Please join me in warmly welcoming Dr. Sharma.
Thank you, Prakriti. Okay, so okay, today I'll be discussing depressive disorders. Before we go into depressive disorders per se, there are certain basic terminologies that you should know of. The first one is a feeling. So what is a feeling? It is a positive or a negative reaction to an experience. It is a subjective experience. For example, you passed an exam, you feel happy. You come across a dog, when you're afraid of it, you feel fear. That is a feeling. Now, emotion is a stirred-up physiological change which occurs in response to some event, which tends to maintain or abolish the causative event. Feeling is just an psychological state. Emotional also includes physiological changes. For example, you're going for an exam, your heart rate increases, you start sweating, you start developing giddiness. That is emotion. The next is mood. Now, mood is a pervasive, sustained emotion or feeling tone that influences person's behavior, color, his or her perception of being in the world. Now, feeling and emotion are a response to an event. Mood is a pervasive thing which stretches across weeks or months. And affect is an observable mood. So, mood is a subjective feeling. I am feeling sad, I am feeling anxious, I am feeling happy. Affect is something that you observe in others. For example, when you see somebody, do they look happy? Do they look sad? That is an affect. Now, depressive disorders are a group of disorders that come under mood disorders. So before we go into what is depression, let's just look at the epidemiology first. History, sorry. Earlier in ancient Romans and Greeks described depression in terms of melancholia. They said that it's a state where a person has aversion to food, despondency, sleeplessness, irritability, and restlessness. Hippocrates, who proposed 4 humors, that is blood, phlegm, yellow bile, and black bile, said that melancholic temperament comes from increase in black bile in the blood. Later on, Esquirol was the first person who separated depression from insanity, and Emil Kraepelin described the core clinical features of depression, that is lowered mood, slowed physical activity, and slowed mental processes. Now, coming to epidemiology, depression is one of the commonest psychiatric disorders in the world, with a lifetime prevalence of 5 to 17%. That is, at any which moment, every 6th person is seen to develop a moderate depressive disorder in their lifetime. Globally, it has a prevalence of 4.4% of world population, and by 2030, unipolar depression is predicted to be the second leading contributor to global burden of diseases. In Indian context, NMHS, that is National Mental Health Survey, was conducted by NIMHANS in 2016, and they saw that depression was the most common mental illness in India, and it was associated with maximum disability adjusted life years among psychiatric illnesses. So what does that mean? That depression caused a lot of dysfunction in an individual, leading to years lost, normal functional years lost in the individual. Now, who are at risk? Usually, depression is most commonly seen in females than males. It is due to various factors such as hormonal differences, psychosocial stressors, cultural expectations that are placed on females, role of pregnancy and related changes, etc. Usually, mean age of onset is 20 to 50 years of age. It is seen that among individuals who have committed suicide, at least 50% of them had a diagnosis of depression. It is also seen that 50% of patients who are depressed usually do not seek help, or it goes unrecognized. Now, what causes depression? Depression has a multifactorial etiology. The etiology can be divided into biological, psychological, and social factors. Biologically, first and foremost is genetics. Multiple family studies, twin studies, and adoption studies have shown that there is increase in 2 to 3-fold risk in individuals when there is a family history of depression. When there is a family history of depression. There are certain genes which are also increasingly associated with depression. There are chromosome mutations in chromosome 12q, 22q11, 9p, 10q, and 14q. Polymorphism of serotonin transporter gene is also increasingly associated with depressive disorders. Coming to neurochemistry, monoaminergic hypothesis is one of the most common hypotheses, which says that depression is caused by deficiency of certain monoamine transmitters in the brain. They have seen that in the synaptic junction, there is decreased levels of serotonin, norepinephrine, and dopamine in patients who are depressed. So what does that mean? When there is decreased level of serotonin, particularly in limbic system and brainstem, it leads to symptoms of depression such as depressed mood, emotional dysregulation, sleep disturbance, appetite disturbance, and increased suicidal risk. Norepinephrine pathway dysfunction, that is decreased norepinephrine in locus ceruleus projection to cortex, limbic system, and spinal cord, leads to lassitude, loss of energy, difficulty in concentration, and brain fog. And decreased dopamine in mainly mesolimbic and mesocortical pathway leads to symptoms of depression such as anhedonia, lack of motivation, and drive. So a monoaminergic hypothesis is what is most commonly followed, and most of the antidepressants usually target to increase either serotonin or norepinephrine in the synaptic cleft. Now, neuroanatomically, limbic system is what is most commonly involved in depression. Especially, they have noticed that in serial imaging studies, in depressed patients, there is decreased volume of amygdala, hippocampus, and prefrontal cortex. In a limbic system, prefrontal cortex usually has inhibitory action on the limbic system. So decreased activity in prefrontal cortex leads to poor regulation of limbic system and emotional dysregulation in these individuals. Apart from neuroanatomy and neurochemistry, certain endocrinological changes are also more commonly observed in depressed individuals. Any individual exposed to chronic stress has been seen to have hypercortisolemia and decreased feedback inhibition of cortisol in the HPA axis. This in turn leads to atrophy of hippocampus and impaired neuroplasticity, leading to depression in these individuals. They have also observed that 5 to 10% of individuals who have poor response to antidepressants in depression have subclinical hypothyroidism. Usually, presence of subclinical hypothyroidism leads to reduced serotonergic function, which is linked to cognitive slowing, mood changes, and decreased response to serotonergic agents. Other hormones such as reproductive hormones, estrogen and progesterone, are also implicated in depression, especially when you talk about disorders such as premenstrual dysphoric disorders, perimenopausal mood changes, or postpartum depression. You can see that any fluctuation in reproductive hormones can also lead to depressive symptoms. So there's a complex interplay between hormonal dysregulation, neural circuits, and neurochemistry when it comes to developing depression. Now, these were the biological factors. Then come certain psychological theories that were proposed on why an individual develops depression. First and foremost was the psychodynamic theory, which was proposed by Sigmund Freud. He said that when a person loses a loved object in here comes, he means in terms of a person or a relationship. So when a person loses an object, he identifies with the object and he internalizes it. And later, the emotions that he feels towards the object are also turned inwards. So he said that when a person loses somebody, he turns the anger of losing that person inwards. That is, anger is turned inwards, which leads to depression. For example, instead of being angry at a partner who left, the individual feels that they are unlovable and they deserve to be abandoned. Now, this is a theory that is no longer practiced much, but this was one of the basic theories of depression. Next, Martin Seligman gave one of the most commonly seen theory. He said that when individuals perceive no control over aversive events, they stop trying to escape or change the situation even when opportunity arises. So what does it mean? He conducted this experiment with two groups of dogs. He kept one group of dog in a box which does not open, the other group of dog in a box which opens on pressing a particular button. He wired the ground with electric supply. He would periodically shock the dogs. The group 1 dogs initially tried to escape from the box, later gradually realized that there is no escape out of the box. The group 2 dogs, whenever there is shock, they would try to escape and somehow found the button and they were able to get out of the box. After repeated stimulations like this, he transferred both dogs into the box which was open and he still provided shock in the ground. What he observed was the dogs in the group 1, who were previously in a box which was inescapable. They did not even try to escape the box even when it was open, when the shocks were given. So he said that when a person repeatedly undergoes uncontrollable negative life events such as job loss, chronic illness, etc., he starts to develop a pessimistic attitude in life. Internally, he starts feeling that everything is his fault or that things will never change, and subsequently stops to even try getting out of the situation. This is known as theory of learned helplessness. Now, Aaron T. Beck provided cognitive model which described the negative thoughts that maintain these symptoms of depression. He said an individual with depression had majorly 3 cognitive thoughts which maintain their symptoms. He called it as cognitive triad. The first and foremost was negative view of self. That is, an individual starts feeling that he is worthless, he is inadequate, he is a failure, he is unlovable. The next is negative view of the future. That is, that things will never improve in the future. The future is hopeless and it is always going to be this way. And lastly, negative view of the world or experiences. That is, the individual starts feeling that the world is unfair. All experiences that he has have some negative connotation to it. Everybody is against him or her, and these obstacles are something that they cannot overcome. He believed that these 3 core cognitive distortion led to a vicious cycle which maintained the symptoms of depression. Lastly, although each and every one of us face one or the other stressor, not everybody facing similar stressor develop depression. So there are certain personality factors and certain coping mechanisms which predispose an individual to develop a depressive episode when faced with a stressor. Most common personality factors that an individual has which increases the risk for depression are, first and foremost, is neuroticism. That is, if a person has high emotional instability, increased anxiety or negative affect as a baseline. Hyperfectionism, if an individual has unrealistic standards for self, they are critical to self or have fear of failure. Or the third is dependency. If a person is somebody who is very dependent, cannot take any independent decisions, has excessive reliance on others, and has fear of rejection. And lastly, those individuals who score high on introversion, that is, those who are usually socially withdrawn with low positive effect, are all the individuals who are susceptible to develop depression in the face of stress. Similarly, individuals with faulty coping mechanism strategies. So what are coping mechanisms? It is how we react to stress when we are faced with stress. So if they have faulty coping mechanisms or maladaptive coping mechanisms, they are also at increased risk for depression. That is one, the coping mechanisms that increase the risk are, first and foremost, is rumination. If they have somebody, when something negative happens, there's somebody who repeatedly think about these thoughts, repeatedly dwell in these feelings. The second is avoidance, where an individual tries to escape from the problems rather than facing it or thinking of a solution for it. For example, those individuals who run away from the problem and turn towards substance abuse or isolation. The third one is suppression. Those who deliberately push away negative emotions instead of dealing with them, they just subconsciously push it down and act as if nothing is wrong in life. And lastly, self-attribution. Just like persons with perfectionism personality trait, patients who attribute each and every failure to themselves and their fault are at increased risk of developing depression. Now, these were the psychological factors for depression. The next are the social factors. Now, social factors can be of usually precipitating factor for a depressive disorder. Now, biological and psychological factors are the baseline vulnerabilities which increase the risk for depression, and social factors usually precipitate an acute episode. So they become a precipitating factor. Most common social factors which precipitate a depressive episode are social isolation, relationship conflict, perceived low social support, financial strain, unemployment, housing instability, adverse childhood events, major transitions such as bereavement, divorce, or relocation, etc. Day by day, what we are seeing in the current generation is also increased use of social media and comparison, because any individual who uses social media comes across posts from their peers where they see much better picture compared to themselves. What happens is, whenever somebody is using social media, we usually try to project our best front. So everybody is going to post about only their successes, only their achievements, only the good things in life. So when a person with all the predisposing factor that we talked about is constantly on social media and is constantly seeing others achieving a lot of things, owning a lot of things, etc., they start comparing themselves with them and start to put themselves down, thinking that, okay, everybody else is having no problems at all in life, and I'm the only one facing such and such problem, which again is increasing the incidence of depression in this group. So why are we talking about all these factors? This is to bring to notice that major depressive disorder does not occur in individuality either from either biological or psychological or social factor. It is an interplay between all three. Any individual with a predisposed biological vulnerability and psychological vulnerability, when they face stress in form of early life pressure, significant life stressors, or environmental trigger, develop major depressive disorder. Now, here is a case vignet. I'll just project on it. What I want to do is, if somebody can talk about what are the factors that contribute to depression in this individual. Now, a 23-year-old female presented with 1 month history of pervasive sadness, profound fatigue. She reported that her mood is consistently low and is notably worse in the morning following receiving a low ranking in NEET PG. She had lost interest in her usual hobbies such as painting and weekend hiking and struggled to concentrate frequently, making small errors, which led to intense feeling of guilt and worthlessness. She avoided all non-essential social interaction and stayed in her room most of the evenings. Premorbidly, she described herself as goal-oriented and a high achiever with family history of postpartum depression in mother. Can anybody talk about what are the predisposing factors and what are the precipitating factors in this individual?
Avoidance.
Avoidance. Yes, avoidance is a what is avoidance in this individual? Is it precipitating, predisposing? Is it a personality trait?
Personality trait, I guess.
Okay, avoidance as a coping mechanism you feel. Why do you feel there is avoidance?
She doesn't want to face the criticism from her family, friends. So she's avoiding that conversation after her
So
NEET
she's
PG. I think.
avoiding facing the consequences of whatever has happened, the NEET PG results. She does not want to face criticism from the family. So you feel she is sensitive to rejection, sensitive to criticism. Yes? Anything else?
Yes, ma'am.
What about her personality? Anybody? Okay, like we talked about previously, depression does not occur just immediately after stressor in every individual. So there is a biological vulnerability, that is, she has family history of postpartum depression in the mother. So there is some genetic susceptibility, increased risk of developing depression in the individual. Pre-morbidly, that is, as a person, she is somebody who is goal-oriented and high achiever. So she is probably somebody who is not faced a lot of failures and who is sensitive to failures. So because that is her baseline, that is her personality, in the face of stressors, triggers such as academic loss, she has developed depressive symptoms. Now coming to symptoms of depression. What are the symptoms of depression? Clinical features in depression can be broadly categorized into mood symptoms, disturbance in biological functioning, disturbance in psychomotor activity, and disturbance in cognition. Mood-wise, a patient who is depressed has pervasive, persistent low mood or sadness, feeling of emptiness, or feeling of being mournful. Sometimes they do not, these individuals might not report of sadness, but instead may complain of lot of physical symptoms such as headache, body ache, heaviness in the chest, etc. These are known as masked depressive symptoms. They also have anhedonia, that is loss of interest and withdrawal from regular pleasurable activity, that is distinct change from previous self. As we talked about in the case with Net, there she was somebody who used to enjoy hiking, enjoy painting, and she has definitely stopped doing such things once she has started having a depressive episode. The next is disturbance in biological functioning. In biological functioning, we've seen that depressed individuals usually have either increased or loss of appetite and subsequently leading to significant weight gain or weight loss. These individuals also have craving for specific food, usually high carbohydrate food. Sleep is usually disturbed with increase in early morning awakening, but some individuals can also have hypersomnia. EEG has shown that these individuals have disturbed sleep architecture with shortened REM sleep latency. Libido is also seen to have decreased in individuals with depressive episode. Psychomotor disturbances most commonly seen is psychomotor retardation. Psychomotor retardation as in there is decrease in psychological activity and motor activity both, leading to decreased spontaneous movements, downward gaze of eyes, slowed speech, etc. In extreme cases, these individuals can also develop stupor. Only in elderly, we sometimes see psychomotor agitation. So elderly with depression sometimes are extremely restless, extremely pacing around, talk excessively. You can also see psychomotor agitation, but most commonly in adults it is psychomotor retardation. There are certain signs on the face which may point towards depression in the individual. The first is the triangular fold present in the nasal corner of upper eyelid. This is known as Varagat's fold. If you see this fold, or omega sign, that is omega shaped skin fold just above the root of nose. If you see these features in an individual, it might be because they have been depressed. We also see fatigue, decreased energy levels. Individuals get tired easily and have difficulty performing day-to-day activities. Cognitively, these individuals have decreased attention and concentration with slowness of thinking, difficulty in making decisions, that is indecisiveness. As we talked about, they'll also have the triad of cognitive triad, Beck's cognitive triad, that is helplessness, worthlessness, and hopelessness. They may have excessive guilt for things that they have not done. Sometimes they may also develop death wishes and suicidal ideations. Death wishes are passive wish to die, while suicidal ideations are where an individual is actively thinking about harming or ending their own life. In very severe cases of depression, these individuals can also develop psychotic symptoms. Most common delusions that are seen in these individuals are delusion of poverty, where they feel they own nothing or they have nothing, or nihilistic delusion, where they feel their body is rotting or they're missing certain body organs. They can also have hallucinations with mostly derogatory content of people scolding them, telling them they are worthless, or telling them that they have done something wrong. Now, these are the most common cognitive disturbances. In special population, that is especially in children and elderly, the presentation is quite different. Children do not come to us with low mood. The parents bring them to us with either externalizing features, that is a child is increasingly irritable, increasingly angry, is getting into fights, which is not his usual self, or internalizing features, that is a child is withdrawing into themselves. They have lost interest in playing. They are excessively clingy towards the parents. They may also bring the child with academic decline, that is sudden drop in performance in the school or school refusal. On contrary, in the elderly, what we see again, elderly also never come to us with complaints of low mood. They either come to us with memory problems, executive dysfunctions, like I said. Cognitive symptoms are a major part of depression. So there is poor attention and concentration. This may lead to a picture similar to dementia, which we usually call as pseudodementia. They may also come to us with a lot of physical symptoms which are unexplained, a lot of aches, pains, fatigue, etc., decreased motivation, and being withdrawn from the community. Now, with all these symptoms, how do you arrive at a diagnosis of depression? The most commonly used diagnostic criteria in India is ICD-10. ICD-10 categorizes these symptoms into major criteria, minor criteria, and somatic criteria. Under major criteria, you have pervasive depressed mood, loss of interest and enjoyment, decreased energy leading to increased fatigability and diminished activity. Under minor criteria, there is reduced concentration and attention, reduced self-esteem and self-confidence, ideas of guilt and worthlessness, bleak pessimistic views of the future, ideas and acts of self-harm or suicide, disturbed sleep, and diminished appetite. In somatic symptoms, they have loss of pleasure in almost all activity, lack of reactivity to usually pleasurable stimuli, mood which worsens in the morning, early morning awakening, marked psychomotor retardation or agitation, significant anorexia or weight loss, and excessive or inappropriate guilt. Now, this is how they have classified the depressive episodes. Presence of those symptoms, major and minor symptoms, the number of symptoms, is what is going to classify the severity of depressive episodes. These symptoms should be persistent for at least 2 weeks. For it to be called a mild depressive episode, an individual should have at least 2 major symptoms and 2 minor symptoms. For it to be called a moderate depressive episode, they should have 2 major and at least 4 minor symptoms. If along with major and minor symptoms, they have more than 4 somatic symptoms, then it is known as moderate depressive episode with somatic symptoms. Similarly, if a patient has all 3 major symptoms and more than 5 minor symptoms with severe dysfunction, they are classified as severe depressive episode. Along with it, if they have a psychotic symptom also, they are classified under severe depressive episode with psychotic symptoms. Now, this is about a typical depressive episode. There are other depressive presentations also, that is called as atypical depression. Here, unlike patients in depression who do not have emotional reactivity for day-to-day situations, emotional reactivity is usually preserved. Instead of weight loss and anorexia, there is significant weight gain and increase in appetite in these individuals with excessive sleepiness and laden paralysis, that is feeling of heaviness in all 4 limbs. They are also very highly rejection sensitive, that is, they are not able to take interpersonal rejections. The second common type of disorder, especially seen in cold countries, is seasonal affective disorder, where patients develop depression in a seasonal pattern. Usually they develop depression in the winter seasons where the sunlight is less, they have low energy, fatigue and lethargy with high carbohydrate craving and social withdrawal, and the symptoms usually remit by spring or summer. The next is dysthymia. Dysthymia is a persistent low-grade depression which lasts for at least 2 hours with lesser severe symptoms, but it is there for most days of a month. The last is recurrent depressive disorder. Here, a patient has multiple episodes of depression with periods of normalcy in between. So once a person develops depression, what exactly happens? Usually, when a person develops major depression, it remits spontaneously within 6 to 9 months, even without any intervention. With intervention, it remits within 3 months. 60% of individuals who have had a depressive episode have an increased risk of developing a second episode of depression. It is called as kindling episode. With each kindling effect, with each episode, that it increases the chance of developing the next episode with significantly less stress. However, unlike major depression, minor depression can go on for years if it is not treated. We have seen patients with dysthymia for 4 years, 5 years, etc. Now, how do you manage a patient with depression? Now, like there is a biopsychosocial model for etiology of depression, management should also include all these aspects. First, you have to take a call on whether to manage the patient on the inpatient basis or outpatient basis. What are the factors that you look for? First and foremost, if a patient has high suicidal risk or homicidal risk, which you are going to infer from presence of past attempts of suicide, presence of psychotic symptoms, presence of irritability, impulsivity, substance abuse, then if they have all these, you are going to admit them and treat them as an inpatient care. If there is significant disturbance in biological function leading to nutritional deficiencies, poor personal hygiene, then again you are going to admit that patient. Presence of any comorbid medical or psychiatric conditions which may require equal amount of admission, equal amount of attention, or lack of response to outpatient treatment might also suggest need for admission in such patients. So once you admit them, you're going to assess the severity of depressive symptoms. There are multiple scales to assess severity of depressive symptoms. Most commonly used are Beck's depression inventory and Hamilton's depression rating scale. Along with assessment scales, we are also going to get few baseline investigations, complete blood count to check for the nutritional status of the individual, thyroid function test, B12 and folate levels, mainly like I said. Subclinical hypothyroidism is more commonly seen in this individual, so it is better to rule it out or treat it appropriately. Neuroimaging is done only when you're suspecting some organic pathology. For example, if you're suspecting a post-stroke depression, then you're going to get a neuroimaging. Now, how are you going to treat? There are pharmacological agents and there are psychosocial intervention. Pharmacologically, antidepressants are the first line of treatment, as you all know. They are broadly classified into SSRIs, that is selective serotonin reuptake inhibitors, SNRIs, serotonin norepinephrine reuptake inhibitors, atypical antidepressants, tricyclics, and MAO inhibitors. Now, MAO inhibitors are something we don't frequently use these days. but otherwise you can use any of the antidepressants. So usually once you start an antidepressant, response is usually observable within 1 to 2 weeks of starting medication, but it is not very sudden. So how do you decide which antidepressant to choose? It is based on the symptom profile of the patient and based on the side effect profile. If a patient has excessive anxiety and physical symptoms, if a depressed patient has increased physical symptoms, sleep disturbance, etc., you're going to choose tricyclic antidepressants. If a depressed patient has more cognitive symptoms rather than physical symptoms, SSRIs are the drug of choice. If they don't have much physical symptoms, it is mild to moderate depression with mainly sleep disturbance, mirtazapine, which is more sedative, can be used. Now, in terms of side effects, if a patient has severe gastritis, if they have electrolyte disturbances, you would like to avoid SSRIs. If they have some cardiac abnormalities, you would like to avoid tricyclics, etc. So the choice of antidepressant is based on their symptom profile and based on their side effect profile. Like I said, now antidepressants take 1 to 2 weeks to act. So in the meanwhile, to reduce the distress, you can always start them on benzodiazepines. If an individual does not respond well to antidepressants, or if they have minimal response, or in case there is increased suicidality, ECT, that is electroconvulsive therapy, is also something which is very commonly used. The other modalities of treatment such as RTMS, deep brain stimulation, have also been tried in depression. Now, for how long are you going to treat these patients? Usually, if it's a first episode, you have to continue antidepressants at least for 9 months to 1 year. In case of multiple episodes, you have to give medications for at least 2 years and gradually taper and see if they continue to be pre-morbid level of functioning after stopping the medications. If they do not, you might have to continue medications for a longer period of time. Now, non-pharmacologically, if a patient is suicidal, you have to advise 24/7 strict vigilance. It is better to treat them inpatient, remove all sharp objects around them, remove locks from the rooms so that they do not lock themselves in the bathroom and attempt on life, etc. And there are certain psychotherapies that can be used in patients with depression. They are broadly supportive psychotherapy, cognitive behavioral therapy, interpersonal therapy, and family therapy. So what is supportive psychotherapy? It is a form of therapy which helps individuals deal with their current distress. So whatever is happening, which has the stressor that has precipitated an episode of depression, you are helping them deal with it, immediately decrease the distress and strengthen their coping mechanisms, increase their self-esteem and build social functioning. Here, you're not going to probe into their thought processes or cognitive distortions which has led to depression, but rather it is a here and now. Okay, this has happened and that is why you are depressed. Let us help you deal with the situation that has caused you distress, right? The next is cognitive behavioral therapy. Now, cognitive behavioral therapy mainly believes that an individual's thoughts affect their behavior and emotions. So if they are somebody who have a lot of negative cognitions, who believe that they are failure, this affects their behavior and emotion. Now, one of the more common examples I give is, let us say you have a maths exam coming up. If you believe that you're a failure, you're not good at math, this affects your emotions. That is, you start feeling anxious, you start feeling sad, your concentration comes down. It also affects your behavior. Because you already believe that you are somebody who is not good at math and is going to fail in exams, you are not going to give 100% to the subject. So your behavior is also influenced. This leads to, again, because you have not given 100%, your attention and concentration is affected. You are obviously not going to perform well in your exam, which is going to reinforce your thought that you are not good at that particular subject. So this is a vicious cognitive cycle that happens in depression. Now, cognitive behavioral therapy acts on identifying these core thoughts that are leading to these behaviors and helping correct these automatic thoughts so that in future when they're faced with stressor, they're able to handle it more effectively. So along with it, there are certain behavioral strategies that are also taught to the patient, such as behavioral activation, that is exercise, keeping activity schedule, going through the day. Instead of even if you're feeling sad, not to sit at one place and dwell, ruminate, but instead keep yourself occupied, follow proper sleep hygiene, etc. Now, the last two are interpersonal and family therapy. They usually focus on relationship with the people around them. It might be family, friends, peers, colleagues, etc., and address interpersonal problems with them. Now, what treatment to give when? It is important that not everybody requires all therapies and all medications. It has to be tailor-made to the individual. Initially, pharmacotherapy targets biological factors such as changes in neurotransmitter imbalance. Along with that, psychotherapy, whether it is supportive, CBT, IPT, or family therapy, based on what is the stressor that is causing the issue and what is the cognitive distortion that is leading to the issue. So, a personalized treatment is key for optimal recovery in a depressed individual. Now that we have talked about etiology, clinical features, and management, what about prognosis? Now, these are certain good and poor prognostic factors which determine chances of relapse in these individuals. If an individual had an acute onset of illness with shorter duration of illness, with no prior history of depression, with good premorbid functioning, that is, personality was stable, they were functioning well, with a strong family support and absence of any other psychiatric comorbidities, they are usually somebody who recover early and also do not develop further episodes subsequently. On the contrary, those which have insidious onset of depressive symptoms without any visible stressor, presence of severe symptoms with multiple previous episodes, presence of comorbid conditions such as substance abuse or disability, chronic medical illnesses, presence of poor social support system in separated, divorced, or widowed individuals, and those with poor premorbid functioning, the personality factors that we have already discussed about, those with such premorbid personality traits and with earlier age of onset are somebody who you have to look out for, but because they have poor prognosis, even when they recover, there is increased chance that they will develop a depressive episode again. Now, your take-home point is that depression is persistent feeling of dullness or sadness or low mood for more than 2 weeks with loss of interest, with a lot of cognitive and physical symptoms leading to significant functional impairment. It has both neurobiological and psychological basis, and management should have an integrated biopsychosocial approach. Any questions? Any questions, doubts?
Ma'am, I have a question.
Yes.
How do we clinically differentiate between typical or atypical depressive disorder versus bipolar depression?
Okay. See, typical and atypical depression, it is basically the presenting symptom, right? If a patient presents with excessive appetite, increased weight gain, increased sleep disturbance, that is when you think about atypical depression. Now, depression with bipolar disorder, usually what we have seen is around 20 to 30% of individuals who are subsequently diagnosed with bipolar disorder initially come with a depressive episode. The initial episode, sometimes it is difficult to make out, but longitudinally, when you take a history, if they give history of either hypomanic or manic episodes where there is periods of increased energy, increased activity, etc., that is when you're going to consider bipolar disorder. Sometimes presence of family history of bipolar disorder or presence of family history of psychotic disorder should also clue you into an individual going into a bipolar disorder in the future, even if it is a first episode depression.
Thank you, ma'am, for that.
Ma'am, I have a doubt too.
Yes.
For patients with depressive disorder and along associated with the bipolar too, So what would be the titration dosages be?
You're saying depression in bipolar disorder?
Yes, ma'am.
Okay. When an individual has bipolar disorder and is currently having a depressive episode, what you're going to do is first stabilize them on mood stabilizers. Because if you don't give a mood stabilizer and directly start antidepressant, there's a chance that they will switch into a manic episode. Right? You start them on mood stabilizers such as lithium or valproate, and wait for a week or two. If the symptoms don't come down with the mood stabilizer, that is when you think of adding an antidepressant. Again, you add with the lowest possible dose and then titrate upwards. For example, if you're starting escitalopram, if depressive symptoms are not very severe, I would suggest you start at 5 to 10 milligrams. But always under the cover of a mood stabilizer. Never start antidepressant alone in a patient with bipolar disorder.
Okay, ma'am. And I have another doubt too.
Mhm.
What about patients who have been under this therapy and then tend to revert back to the usual, like if there is any rebound sessions? So what would be the right therapy be? Is it like more of medically, or else is it more of like a CBT or else intervention kind of a therapy?
If a person is having a moderate to severe depressive episode, you should always give them an option of medication along with therapy, because therapy is a long-term process. It takes a few weeks to months sometimes, and therapy also requires a lot of work from the individual, which requires a lot of cognitive capability, right? So you should always give them an option, ideally start them on antidepressants and then send them to therapy. Now, therapy, there is a chance that it is going to fail, because, like I said, it's not just what a psychologist or a psychiatrist talk to the patient about. It is also a lot of inner work that they are supposed to do in the period between the sessions. So if somebody is not very cognitively oriented, who is not able to give so much time and effort for therapy, then I would suggest medications as the first line of treatment.
Ma'am, I have one more doubt as well.
Yes.
So, in patients with especially with bipolar one, like with depressive episodes, I've seen patients they have a common history of child abuse,
Hmm.
and I have seen patients who have been disturbed thanks to their current conditions and not have any past history of trauma.
Hmm.
So, I mean, like, which one has a better prognosis compared to the other?
Individuals with a childhood history of adverse events generally have poorer prognosis, because that leads to, like I said, maladaptive coping mechanisms as an adult. They have poorer prognosis as compared to those who had uh, not a very significantly disturbed childhood.
Okay, ma'am, that's all I have.
Yeah. Anything else?
If there are no other questions, I would like to conclude the session. I'll open it for 1 more minute for any questions related to the event. All right. With that, I thank you, Dr. Sharma, for the engaging and meaningful session on depressive disorders. Your perspective on identifying the subtle presentations and approaching the management holistically were truly valuable. And we also appreciate the practical insights and academic depth you brought to the session. So, as we come to the closure of today's session, I would like to extend my heartfelt gratitude to our speakers for generously sharing their time, their expertise, and their clinical wisdom. Your sessions on OCD and depressive disorders have been truly meaningful and gave us very practical insights that will help us certainly enhance our clinical approach. So I also express a sincere appreciation to IMMS in Karnataka and Clinically Evolve for the valuable support and collaboration. With that, I hand over the mic to Srinidhi.
Thank you, ma'am. Thank you for the wonderful session. Now it is my privilege to invite our respected president, Dr. Veerbhadraya TA sir, to deliver the presidential remarks on the webinar.
Good
Over
evening,
to you,
everyone.
sir.
Good evening, everyone. Thank you, Srinidhi. Thank you, both the speakers. It was wonderful speech on webinar on OCD and depression. Very important topics for both students as well as practitioners. So on behalf of IMA Karnataka State Branch, congratulate the organizers and thank both the speakers. Thank you very much.
Thank you so much, sir. Thank you for supporting us. Next, I invite the chairman of IMMSN, Dr. Jaspal Singh Talia, sir, to address the gathering.
Thank you, Srinidhi. First of all, I would like to thank both the speakers for today's webinar, Dr. Vatsalya Gowda ma'am, as well as Dr. Kshama ma'am, who gave a fantastic and informative talk on the subjects which were of much interest to our students to understand, because they were asking this particular session since quite long time. And I also thank the moderator of today's session, Dr. Prakurti, who has done an excellent job. I thank Dr. Srinidhi, and I thank everybody who has been making the time available for today's and yesterday's session. Dr. Veerbhadraya sir is constantly being with us since yesterday. I thank Dr. Veerbhadraya sir especially finding time on Sunday and being continuously till the end. And I wanted to also make a mention that Dr. Harish Dalantabettu, who is a senior psychiatrist, who is the incoming president, was available with us for quite a long time. He just left, I think, 10 minutes back. Thank him also. Dr. Rajendra Prasad sir also is there. I see many presidents, Dr. Krishnananda Malya from Udupi and Dr. Nagbhushan Udupa had joined from Indapura. I thank all the members, students from MSN. And now I hand over the mic to Srinidhi to take further with the vote of thanks.
Thank you, sir. Thank you for your inspiring guidance throughout the webinar and throughout the preparation, everything. As we come to the conclusion of today's webinar, I now invite Shreya S. to deliver the vote of thanks.
On behalf of the organizing team, I extend our sincere gratitude to everyone who made today's webinar on emotional processes and associated mental health conditions a meaningful session. We are especially thankful to our distinguished speakers, Dr. Vatsalya Gowda Madam and Dr. Kshama H.G. Madam, for their insightful and comprehensive presentation. We also express our heartfelt appreciation to our moderator, Dr. Prakriti Madam, for guiding the session so smoothly and ensuring a focused and engaging discussion. A sincere thank you to the organizing team for their efforts behind the scenes and to all the participants for your active involvement. Thank you once again to everyone for being a part of this session.
Thank you all. We can end the session.